Good morning and welcome to Optima Healthcare Insurance Services webinar, Skin in the Time of COVID-19. I'm Millie Mastramati with Optima and your program moderator. We've got a great program for you today. Our speakers have presented this multiple times to a wide range of audience, and we appreciate that almost a quarter of our audience today is long-term care professionals, and we commend you on your interest to increase your knowledge of skin and wound care challenges in acute care, because we know that those skin issues don't immediately heal on discharge to your facilities. So welcome everyone. Just a quick housekeeping note, you are muted. Please submit your questions through the Q&A feature. We will address them at the end of the presentation. Our speakers today are Drs. Holly Kirkland-Kine and Emma Blackman from UC Davis Medical Center. Dr. Kirkland-Kine is a PhD nurse practitioner with extensive clinical experience in maternal child health, disaster relief, and now works as the Director of Wound Care at UC Davis. She is also a clinical professor performing research and training on interdisciplinary team initiatives in street medicine and wound care in low resource settings. Dr. Emma Blackman is also a PhD who worked in adult critical care for the last 16 years. And in 2016, she transitioned to the role of adult critical care educator at UC Davis, focusing on education and training of adult ICU nurses, serving as a critical care bedside resource and member of several interdisciplinary teams. Welcome, Drs. Kirkland-Kine and Blackman. I will pass the floor to you now.
This is Holly, and I'm starting out today to talk to you a little bit about skin in the time of COVID. And I think it's important for us to share this with you because these skin issues often don't heal by the time we get the patient's discharged. So it's a good thing to know. Sorry. Okay, so what's the big deal? So obviously there's a big issue around pressure ulcers and pressure injuries within patients when they're in a hospital facility. So again, we're looking at stage 3 and 4 pressure ulcers that occur in patients who have low perfusion and in patients who are very sick in the hospital. But I'm sure you have those issues as well, patients who are very sick who develop pressure injuries. So we wanted to make sure that we didn't have people getting these COVID lesions confused with pressure injuries. So speaking of the costs, obviously litigation is a cap of $200,000 if it's for malpractice. However, in cases where patients develop hospital-acquired pressure injuries, oftentimes it's neglect and abuse that people sue for, and there is no cap on neglect and abuse. So again, reporting to the state, any hospital-acquired pressure ulcer that is a stage 3, 4, or unstageable needs to be reported to the state within 5 days. We report it to Leapfrog, and consumer reports will come out to say, you know, if you have a high incidence of pressure ulcers or injuries within your facility, perhaps you don't have the best nursing care. And we're here to say that, look, it's not all about the nursing care. State has fines if we don't report within a few days to make sure that that people are living within those rules. And University Health Consortium also has fines for this. So Medicare has refused to pay for anyone who develops a hospital-acquired pressure ulcer for their care to do with that. And oftentimes these pressure ulcers, pressure injuries will take up to a year to heal, specifically if they're on the sacrum. And if you're going to treat that patient with a wound vac, that's $100 a day, a year of treatment. So again, it's very expensive, and you could also have fines. And so again, patient risk and morbidity and mortality for pressure ulcers and injuries that occur in these very sick patients. So warning, I have some graphic content here. The following images are not for the faint-hearted. So we're starting off kind of easy here. This is an unstageable pressure ulcer injury on the nose, and this is from BiPAP. And we found that you know, we're in a hurry to get people ventilated during this time, and there would be a lot of pressure perhaps over the area. You don't want any leaks, and so we were actually causing a little bit of damage to the skin. However, when you stop the BiPAP, these will go away easily. The others are not so easy to heal up. trach plate after being prone for 12 hours. This is a patient, unfortunately, we happen to have the fires here in Sacramento, and because we're a level 1 trauma center and we also have burn patients who come here, that all came to a nexus at the same time. So as we were getting patients from all over the state to come for burn care here at UC Davis, we happened to get a peak in COVID cases at the same time. So here's a patient who needed to have multiple surgeries, had a lot of burns, and then had to lie prone for his COVID, and at the same time ended up with this pressure ulcer from his trach. Here's a patient who's on ECMO, and you can see here, because of the medications that we gave a lot of the patients to keep them from coagulating, there was a lot of issues around clotting and clotting abnormalities. And this is a patient who was on ECMO. You can see these large blood blisters that occurred around the tubing. And here's another one. And this is a patient's back. And again, he was on ECMO. He had all the usual treatments for ECMO, and he developed these blood blisters on his back. And people wanted to call them pressure ulcers, but they're very regular. Something else happened here. We think it's a superficial thrombotic event. And again, we're just watching, making sure we treat these accordingly, but we're not calling everything that we see a pressure ulcer, because again, we had not seen these in the past. So here's a deep tissue injury that occurred 3 days after having a cardiac catheterization. And we were finding these injuries. You can see how it looks like a big bruise along the sacrum. And this patient, when we looked back at the medical record, we found that this patient probably was transported with this. And if you have very low blood pressure and you're strapped down onto a backboard, or you're strapped onto even a gurney, and you're traveling from Redding or Northern California, or you're getting some sort of treatment here, and then you go onto a hard table for another few hours, your perfusion is very low. We found that people develop these deep tissue injuries, and that these evolved into stage 3, 4, and unstageable pressure ulcers. Here's another deep tissue injury that you wouldn't think that you would find on a soft area. They often say that these happen over bony prominences. You can see here, these patients, it wasn't really on a bony prominence. If you look at the sort of securement device that they have, it looks really soft. You'd wonder how that could cause any sort of pressure around the neck, or around, in this case, on the woman on the right. She came to us from an outside hospital, a 33-year-old who'd had DIC after having a baby. And we had the trach in, and we were very consistent about keeping the trach right. You can see she also was very jaundiced, but she developed a pressure injury that became this unstageable pressure injury, and she needed to have a graft to cover that in the end. So again, even in soft areas, if people have other organ damage going on, it can cause some skin issues. And again, we're busy looking after keeping them breathing, keeping their heart going, keeping the perfusion going as well as we can. And in the end, their own systems can work against them. And again, endotracheal tube securement devices. We've since gone to the anchor fast. In the past, we used tape and twill, and what we had was a lot of these breakdown around the mouth. And you can see here that they had, we had a couple of patients who developed what I call the UC Davis smile, unfortunately. And it was sort of a Joker-like scar across their face from the ET tube securement. And we do want to keep those people secure. And oftentimes, I think, especially in the prone patients, when we were proning patients for the COVID issues, then we found that if we used anything other than the anchor fast, that they did have issues around swelling and some pressure ulcers around the face and mouth. Here's a medical adhesive related injury. And I think oftentimes when people use the anchor fast, it has a hydrocolloid, sort of a tape thing or securement on the cheeks. And that actually holds it in place better than the rest. You can see this gentleman actually has an area on his ear where it was, perhaps the strap was going down as well. But you can see when he pulled out his ET tube and he pulled off his hydrocolloid off his face, he pulled off a lot of his skin. And that's medical adhesive related injury. It's not due to pressure ulcer. And this is another medical adhesive related injury. And this was in a patient who, again, had COVID. We pulled off his hydrocolloid and found this, superficial bleeding going on that clotted. And again, these patients had a lot of issues around abnormal clotting. And here's a patient who was originally on a rotoprone bed. And, the rotoprone bed costs around $1,200 a day, and it takes a very long time to get a person secured within the bed. You have to lock them in. And I don't know if you've ever tried it. It's very scary to be a patient in one. I tried one myself just to see what it was like. And you can see he developed this pressure ulcer on his face that left scarring, and that's unstageable and had to be reported as well. And he was young. So he had good perfusion, but a little bit of pressure over the face because you're not used to having those kind of pressures in those areas. This is a patient who came in early on during COVID, and he was a 40-year-old male who had this irregular rash-like thing. You can see all the swelling that he had. He had some cardiac issues, and this is livedo reticularis. This is a rash. It's a lacy type rash that you'll see on the skin, usually with autoimmune disorders. And we knew right away that he had some sort of viral condition that had brought this on. And this was, again, early on within the COVID. Here's a patient who had spent 16 hours prone. We turned him over on his back for about 2 hours, and then we turned him prone again. However, when we had him prone, we were able to take a photo, and you can see this looks like what you would think is a deep tissue injury, but we found out about these. We call them COVID lesions because, again, they have this superficial clotting disorder. They're calling it most likely due to a vasculitis, and it's not even over a fatty or a bony prominence. And so these really, we're calling these COVID lesions, and we're trying to just monitor those and not, and they're pretty superficial, most of them. And we don't want to call these pressure ulcers because, again, those have to be monitored much longer and they have to be reported to the state. And it gives the impression that we're not really doing the right thing for people. Here's another one. This is, again, a COVID lesion. There's sort of, if you look at the borders, they have that sort of snake-like border. We call that a serpiginous border. They're not directly over a fatty or a bony prominence. They're more over on the fatty areas. And we found them all over, sometimes on a hand, sometimes on the legs. Here's another one. It's this patient had this, and if you look at this, skin has come away. This is a COVID lesion, has those serpiginous borders. The superficial skin has come away. You can see that this is not really deep, like a deep tissue injury would be. And here's another one. Again, they could be sort of scattered, irregular shape. I think we could do like a little Rorschach test on that to see what people think it looks like. But it definitely, we call these COVID lesions, and we're actually collecting data on being able to publish an article on these right now. Here's another one. Again, you can see as it starts to slough away, it's not deep like the deep tissue injury. These are usually superficial, and we think it's a superficial vasculitis that causes this breakdown. And here's us treating this one. It was the first one that we treated, and we just used some cream on it and kept him off of it. And you can see it is very superficial, unlike a pressure ulcer. Here's one on the hand. This gentleman, I thought originally maybe he had some sort of injury to his hand. He was transported from an outside hospital, but no, this was just one of his COVID lesions that he developed on his hand. And you can see after a few days how it sort of, it looks like the rest of it. And here's some of the issues with the vasculitis. He had superficial vasculitis, but also vasculitis where he shot clots of blood to his fingers and to his toes. So, these are COVID toes, or also, we used to call them Janeway lesions, but it's from a shower of emboli that you get from the COVID itself. And I just wanted to show that vasculitis itself looks different. If you look at this, this is actually a punched out lesion that a person had from vasculitis and from arterial disease, and you can see she has a couple of those. They're very painful, and she has some amputations as well. Again, totally different than what you see with the COVID lesions. And here is a pathognomonic of a COVID lesion, but also it could be confused with levamisole associated vasculitis. So what happens at least in California, is that oftentimes people will buy cocaine and they lace it with levimazole, which is a horse dewormer. And when you mix the two together, it causes a superficial vasculitis. It does potentiate the action of the cocaine, but at the same time, they'll get these lesions. And if you see a person who has a purple lesion on their ear, it's either the levimazole induced vasculitis, or it's from COVID. And I just wanted to show you the difference. This is a deep tissue injury. So this is a 65-year-old gentleman who came in who had aortic fistula, and he was taken straight to surgery. Came in, obviously walked in the door. He went straight to surgery. Had 20 hours of surgery, and had 2 cardiac arrests on the table. But just to show you how great our surgeons are here he is standing at the bedside, and nursing care. Here he is standing at the bedside the next day, and you can see he has that deep tissue injury. It too looks a little odd, but it's right over his sacrum. And he was, again, had a Braden that was completely normal, ate, walked perfectly out of bed all the time. And you can see here it is 3 weeks later, it's become that hard eschar, which is what they do, because you're looking at that top one is just the tip of the iceberg. And you can see where the bottom one, it's starting to necrose. And this gentleman took his pressure ulcer, even though he was completely ambulatory the entire time and eating and doing everything according to how he was supposed to, that it still took a year to heal. So what we found here, this is a research article that we published 2 years ago or 3 years ago now, and it's really about pressure ulcers that occur in acute care. And we created this pressure ulcer acute care risk assessment. Now, the Braden itself, the risk assessment for a Braden, was really created over 30 years ago for long-term care on 30 patients. And while it's probably good for long-term care, it does not hold true for people in acute care situations. So what we looked at was 8 to 10 years of data here at UC Davis. And every single patient who developed a hospital-acquired pressure ulcer, 100% of them started as deep tissue injuries. And they started within this group: people with low blood pressure, people who had a low hematocrit, again, any kind of shock, septic, neurogenic, cardiac, and patients on dialysis. And I wondered about the dialysis patients, and they said, well, look, they already have a low perfusion. You take half of their blood out of their body and you put it into a machine and you tell them to lie really still for 3 hours. Of course, they're going to get them. So yes, these are the patients who developed them. When you see the ones on the bottom that have the 2 asterisks, those were from further studies that we did on patients coming in from the community. So in other words, if you have a spinal cord injury and you had spina bifida, most likely you might have had a pressure ulcer in the past. Those people were coming in and they might have their skin completely healed over, and people didn't recognize that. It doesn't matter. Once you're a stage 4 pressure ulcer, even if it completely closes over, you're always a stage 4. So if you don't identify that when people come in the door, then you may own it when it opens up again, because that skin is less than 60% as strong as the previous skin that was there, the normal skin, because it's scar tissue. So, and again, it's stroke and neurological disorders as well. Make sure that we check those people, and if they have a previous scar tissue, that we identify as present on admission. So recommendations: we use the silicone dressing over when we're sending people to the OR, or even in the hospital. We're using silicone dressings for prevention. And we do a skin assessment. We're doing photos for everyone, especially present on admission, to make sure that we don't own things we don't need to own. And interventions. Make sure you look after, I call it the skin bundle, look the surface, the keep repositioning, make sure that you have something for moisture management. I is incontinence, and in for that is nutrition. Okay, and now Emma.
Thank you, Holly. Good morning, everyone. Just wanted to talk about something that we've seen increasingly at the hospital here at UC Davis over the last year and a half, and it's really kind of what brought Holly and us together to talk about this. Is to seen a lot of patients that we've been proning due to COVID, and when patients spend a prolonged period of time on their belly, they are at much higher risk for pressure ulcers developing in areas that we don't normally anticipate. So it's really what brought sort of Holly and I together. So please bear with me as I kind of go through this more critical or acute care part of the presentation. So prone positioning. So why do we prone patients? So in the intensive care units, we prone patients because patients have very, very poor oxygenation. They're usually diagnosed with ARDS and they have very, very low PF ratio. So that's basically the fraction of the partial pressure of oxygen to the amount of O2 we're giving, qualified as FiO2. We prone patients because what we tend to get is a more even distribution of ventilation when patients are lying on their backs for a prolonged period of times, you know, all day and all night. The dorsal lung becomes non-dependent, and then we get this VQ mismatching. And so basically what happens is when we prone patients, we get more homogeneous ventilation, which is really nice. We get re-aeration of dependent areas of the lungs. We relieve some cardiac and abdominal compression, and we get better gas exchange. And so basically that's why we prone patients. And research has shown that the longer patients can be prone that have severe ARDS, the better they do in the short term. And so that's what we've been doing here at UC Davis for a long time. And like I said, kind of what brought how Holly and I sort of started working together. So like I said, just a visual representation of why proning works. And as you can see in the supine position, which like I said, almost all the patients that you're going to see are going to be in the supine position. And so basically what happens is the alveoli that are on the anterior portion of the lung get over distended, and once we prone them, there's just more homogeneous ventilation. There's more even blood distribution and blood flow, better oxygenation, like I said, better outcomes for our patients. But this does not come without risk, as Holly has really sort of graphically illuminated. So the proning procedure is not something we need to cover today, but this is just a resource for you guys. It's really what we modeled our proning procedure off of here at UC Davis. It has a lot of the research that sort of went behind prone positioning. Prone positioning is not a new thing. We've been doing it for decades, but it's definitely having its day in the sun right now because of COVID. And so we're seeing tons of patients prone, not just in the ICU, but even on the acute care areas that are self-proning or proning, patients that are not intubated, they're being proned. And so these patients, because of the complexities of the COVID diagnosis, these patients are at much higher risk for developing pressure injuries in the future. So prone positioning in COVID-19. So we see patients, our hospital is pretty large here at UC Davis, so we see patients all over the hospital that we're seeing with COVID and that are being proned. So we've seen a lot of patients in the acute care areas that are self-proning. These patients are obviously spontaneously breathing, but they might be extremely hypoxemic due to the COVID disease process. They could be on anything as regular as nasal cannula. They could be on high flow nasal cannula or BiPAP. We really have to be very thoughtful though about patients that are not in the ICU that are self-proning. So lots of things to consider. So they have to be able to independently prone themselves and then turn themselves back over. We want to make sure that these patients aren't delirious, obviously don't have any nausea and vomiting. We want them to prone themselves for at least 30 minutes, about every 2 to 4 hours if they can tolerate it. But clearly if they develop any hemodynamic instability, multi-organ system failure, any dyspnea, we want to discontinue this and put them in a more closely monitored area. But as you can see here, the tendency for patients that are awake and not intubated and sedated is to cross their legs, to put their arms in different positions. But it's better for these patients to be able to move their limbs independently, but still because of the COVID disease process and because we haven't really been able to get like a really, really great handle on COVID, generally speaking, is these patients can deteriorate rather quickly. So we just want to make sure that we keep in mind by the time they reach the ICU, have they been self-proning? Are there areas that we need to be concerned about already before we continue proning these patients? So positioning patients in COVID. So there's lots of things to sort of consider, especially in the ICU setting for these patients. We see a lot of very, very critically ill patients. And so do they have a lot of lines and tubes? And then clearly you can see here, this lady is intubated. Can they tolerate the position with all those lines and tubes? And do they have chest tubes? Per the literature, we prone patients for 16 to 20 hours a day. Now, I will say that was pre-COVID sort of standard, 16 to 20 hours a day. In the throes of COVID, all of our regular sort of rules and guidelines sort of just went out the window. We've had several patients across all of our adult ICUs that are prone 23 hours a day. Some of them just cannot tolerate being supine because the COVID disease process is so severe. And so when we have patients prone 23 hours a day, that's a whole surface of their body that we cannot easily assess. And so, like I said, they're very, very high risk for potential for pressure injuries. And like Holly was saying, all those COVID lesions that we have seen on our patients. So clearly, we try to avoid proning patients with any hemodynamic instability, open abdomen, traumatic injuries, or ICP. But that being said, we have done all of those things in the last year and a half because the proning does really seem to help patients in the short term, help them recover from their COVID disease process. Oops, sorry, clicker there. So lots of pressure injury risk factors, though, for critically ill patients, and especially patients with COVID. Holly already alluded to this, but a lot of the patients in the intensive care unit already have or present with impaired tissue oxygenation and perfusion. And so like Holly was saying, when our patients are hypoventilated and hypoperfused, we already put them at risk. So their baseline risk is already elevated. Clearly, patients in the ICU have decreased mobility, and then we start to prone them and they have even less mobility. So this is really a passive thing for this patient. When the patients are on the acute care floors and they're manually proning themselves, and that's a very different thing. But proning patient in the ICU is not mobility in the traditional sense. It is completely passive movement for the patient. These patients are heavily sedated, if not paralyzed, when we do this. And so there's increased risk for friction and shearing because our patients cannot tell us if they are uncomfortable. They can't tell us if something is pinching or anything like that. So we have to be super mindful about proning these patients. Lots of patients in the ICU are on vasopressors, which decreases their perfusion. And obviously securement of the ET2, which Holly sort of talked about already. And then globally across the board, I would say ICU patients do not have the nutrition that they need. It's not for lack of trying. It's just sort of issues with the patients. Other significant variables for pressure injury development, I think Holly showed some pictures about this. BMI, obviously, and age are going to increase your patient's risk. Their SOFA scores, like I said, vasopressor use, malnutrition, all of those things are going to contribute to potential risk for your patient to develop a pressure injury. So other considerations, like I talked about, prolonged proning episodes. Pre-COVID, like I said, 16 to 18 hours was usually the norm, but now we're looking at patients that are prone 23 hours a day. We did have a young woman in one of our ICUs in the last 2 months who was prone for 7 days continuously. She could not tolerate being supine at all. She was that critically unstable. So if you can only imagine, the potential risk for her developing pressure injuries is extremely elevated. There are limitations, though. We have proned very heavy patients up to 500 pounds, but it does depend on body habitus and sort of distribution of weight. I will say it's much easier to prone somebody who's 350 pounds, who's 6'8", versus somebody who's 350 pounds, who's 5 feet tall. There are just logistical sort of limitations. You can see this woman here who's proned. We try to be really mindful of their position. So making sure that their head is turned every 2 hours, making sure their limbs are moved every 2 hours. We like to put them in swimmer's position is what we call it. But some patients can't tolerate that. They have decreased joint mobility. So we have to just make accommodations for each patient that we prone. But this is also going to lead to potential pressure points for these patients. So clearly we want to make sure we avoid proning patients with these contraindications, but like I said, COVID sort of threw all of our rules out the window. So this comes from the NPIAP. I'm sure you guys are all very familiar with this. So when we started proning all the time because of COVID, I spent a lot of time with the intensive care unit nurses discussing pressure points. Not that they weren't concerning pre-COVID, but we were proning on such an infrequent basis pre-COVID. Our numbers of proning have just skyrocketed. I don't know the number today of how many patients we've proned, but it is very, very high. And so we had to really sort of rethink what we were doing when we were proning patients. How could we anticipate what their needs were? And working with Holly, able to get a lot of devices in our hospital, lots of specialty pillows and dressings. And I used this diagram to help the nurses sort of understand where we would be looking, especially after the first prone. So what we did prior to proning was ensure that we mapped out sort of where we thought their pressure points were, that we covered them with our Mepilex dressings. And then after that first proning session, when they went supine, re-examining the skin very closely and all these pressure points, and then potentially identifying any other pressure points that we would have missed prior to that first prone. So proning recommendations, like I said, this is specifically for the intensive care unit, making sure that the head is supported, that we use pressure redistribution surface. So we actually have moved to recommending the full waffle mattress for all ICU patients that are going to be prone, because it just creates that nice extra layer, allowing for airflow, which is super important. Using the prophylactic dressings under devices, that's really, really important. We don't put anything under the anchor fast, but just making sure we create a supportive structure underneath the head when the head is turned to the side. Supporting all the lines, tubes, and airways, obviously keeping the head of the bed flat and then then using reverse Trendelenburg bed position for these patients, and then obviously frequent assessments of their face and body. So these are some of the devices that we use. I guess we use the MedBox here. You see the Z Flow pillow up there in the upper left corner, and then this is a bariatric seat cushion, which we actually found to be incredibly helpful, folded in half to create lift for the chest. When patients are prone, your patient who is sedated and possibly paralyzed is seems heavier than they actually are just in kilograms because they cannot move at all. So just really utilizing all of our devices that we have to create not just support for our patients, but pressure relief is what we're really, really looking for. So I'm just going to review a case that I should update. It's over a year old now, but this was really when we started to see issues with proning and in our COVID patient populations. This is probably the case that brought Holly and I together, is what I imagine. So we admitted a 55-year-old male last April, obviously 4 days prior to arrival, some onset of shortness of breath, chest pressure, all of the sort of classic symptoms of COVID early on. No significant medical history at that time. He had an acute onset of symptoms and he was diagnosed as COVID positive. 24 hours admission. He was placed on high-flow nasal cannula at 60 liters at 90%, which is a lot. So all of our patients that are placed on high-flow nasal cannula, if they're not in the ICU, get an automatic critical care consult because these settings would indicate to us that this patient is on track for respiratory failure. So he had increasing fatigue and shortness of breath. I'm so sorry, I've got something in my throat. He was intubated 4 days after arrival and obviously secured his ET tube with our AnchorFast device, which is what we use for, I would say, 98% of our patients. 24 hours intubation, the patient was prone, which is typical. Pre-COVID, we would usually wait about a day for stabilization of ventilator settings and hemodynamic status. So he was prone for 3 days. A consult for ECLS, extracorporeal life support was consulted, but they ultimately decided not to do that. But after 3 days of proning, his progress improved, his PF ratio improved, which was great. And then we had a note of facial skin injuries. So on the right cheek, and we're going to show you some pictures, there was some skin injury after 7 days. And after 11 days, there was an injury on the left cheek. And so wound care was consulted, and they provided us some recommendations for this patient. So as you can see here, and I think Holly showed you the AnchorFast, and it was on my little mannequin that was on the picture a few slides ago. So you can see on the right cheek that there's an area where the skin has lifted, and you can see sort of that, what looks like sort of bruising underneath that area of skin right on the zygomatic process there. And that's a little bit picture of it a little bit closer up. So that's on his right cheek. And then on the left cheek, what you don't see any sort of skin removal, but you kind of see that really sort of deep, like I said, almost looks like bruising underneath there. And then that skin is really irritated. But as you can see, looking back and forth here, as that because he was prone, the distribution of skin injury is not equal. Right. And so it really just depends. When our patients are prone, we turn their heads from side to side. That AnchorFast doesn't move, but it does shift based on the patient's weight and his body habitus. So you can see that the wounds and the injuries are not equal from side to side. So that's him. So straight on. So you can see that's a really nice picture. So on that right side, you can see he was probably a little bit more even distribution when he was face down on that side. And on the left side, it was probably just a little unequal depending on whether they used a supportive device underneath him or not. So a little bit unequal sort of distribution there of the pressure injury. Oh, okay. Holly.
So I have this view. This is actually of pressure mapping. So we had a grant from the Children's Miracle Network to be able to pressure map people on different surfaces. And this is what we found. You can see here that the pressures, which is symbolized by the red areas, are sort of, you can see highlighted over the occiput, even on one area of the scapula and on the sacrum. And then when we change this, you can see that we have the waffle seat cushion just under the sacral area. And you can see how the pressure has been redistributed across an entire surface. So this was actually one of our very fit physicians from the OR, our surgeon at the time, that we said, we want you to pick out our best surface that you want to trial to see what it's like. And we pressure mapped it, the two surfaces together. So again, the gel mattress that is very expensive on the top, and the actual $16 seat cushion on the bottom. So you can see how it really works well. And you need to have the numbers. Just the colors aren't good enough. So we would look at the numbers. You're looking at the surface area too, to see how it has redistributed the surface all over. This one? Okay, so we did supine measurements too and comparisons on different surfaces. So we used our pressure mapping machine to trial our regular bed, and we had a couple of specialty beds that cost around $85, $100 a day to rent. And we were convinced that, you know, maybe the more we paid, the better we were going to get any sort of you know, outcome. But you can see here, you want, again, the lowest peak pressure, and you want the highest surface area. So what we found was with that waffle cushion, that it gave us the best outcomes for patients when we did the measurement. And so we're trying to use those more and more, especially in people who are immobile, and sending patients home with these, because we're finding a lot of patients, they get the best of care in the hospital, they get home, and they may not have someone who's going to keep them turning and help them in the bed, things like that. So here's, again, this is a picture of all the different the pressure mapping we did on that day, and we did supine as well. So we did supine and prone positioning on different surfaces. And again, you're looking for the lowest peak pressure and the highest surface area. And the best outcome was always when we tried different people. We actually did our lift team, and we even did Emma here. We used to go down to what I called the bed cemetery, where we have all the old beds, and we would make a fun day of it, tell people to come on down. We're going to pressure map people, because we wanted all different sizes of people. And so we were looking for, you know, bigger sizes. Emma's a little small, but we had to look for people with a BMI above 30, which is kind of our average patient. And here's another thing we did was we pressure mapped these donuts. Our surgeons love the donut, and you can see they like to use it in the OR a lot because it stabilizes the head. This is a 24-year-old gentleman who developed this pressure ulcer that became unstageable on the back of his head from this donut. And it's not the pressure, as you can see, it's not so much the pressure from the donut, because the donut's not causing any centralized pressure. You can see that it acts like a tourniquet on the scalp. So again, you know, we're trying to get people to move away. Let's measure things. Let's move away from what doesn't work. And interventions, again, managing moisture, pressure redistribution. When you think about what happens with pressure ulcers, there's two things that really cause pressure ulcers, and it's pressure, obviously, and shear. And the reason that shear is different is like when Emma showed the photo of the gentleman with the wounds, the pressure ulcers on his face. It wasn't that it was pressing there. It was the fact that it had moved the entire skin up on over the bony prominences. And that's why oftentimes we'll see physicians, they'll admit a patient who has an ischial pressure ulcer, but they'll say pressure ulcer on the perineum. Because of that, when you're sitting, you get that shearing effect. And again, here's the full length one. And I think these are like $35, and I'm trying to send them home with patients because again, they help people to be able to pressure redistribute at home. And when we find people who have immobility issues at home, people are having a hard time moving them too. So again, just to give everyone all the tools that they need. And we started using them in the emergency department, because we found that sometimes people would be down in the ED for a long period of time. And you can see the picture on the bottom where it says pressure mapping on the gurney with the head of bed up. We know that the best position for prevention of pressure ulcers is flat, but no one is flat. Everyone is preventing VAP. Everyone is looking around. I tell you one thing, I'm in that emergency department. I'm sitting up because I want to see who's coming in that door and what they have in their hands, right? So you can see as we put the head of the bed up, how that shearing occurred and more pressure over the sacral area and the buttocks. So again, 0 degrees is the best, but no one is at that, especially when they're in hospital. And I know when people on ventilators, tube feeds, all the rest of it, they need to have the head of the bed up more, and you can see how it causes more shearing and pressure. And again, we're doing everything we can for prevention, because once you have that deep tissue injury, it's going to open up, and it's going to be there possibly as a stage 4, and then take over a year to heal. So again, some of the things we've changed to is we're now looking for silicone options to be able to prevent the pressure ulcers around the trachs. And again, we a few years ago, I want to say, wow, it's going to be 6 or 8 years ago, we went to the Anchor Fast, and you can see the hard plastic on it when people are lying prone, and if it pushes on their face, how it moves up and it goes over the zygomatic arch. So what's next? More research, more looking into it, more working together, and see how this disease and the skin manifestations evolve. So I think we're ready to take questions.
Yes, thank you.
Okay, thank you very much. That's a lot of information. So a lot of really great information. So if anybody has any questions, please feel free to put their questions in the Q&A. I also, I don't see anything in the chat either. So I just real quickly, while we're seeing if anything wants to come in, regarding documentation and guidelines about what should clinicians use for naming the wound, like if they have a COVID patient and they're not really sure if it's pressure or if it's a COVID related, how do you guys decide what exactly to document so that if it does come back later and say, oh, this is a pressure wound or something like that, how do you guys decide on that?
So what we do is we have a team here, and we work with a plastic surgeon as well. But our team of nurses on our wound team, we get together and we say, through inter-rater reliability. In other words, we all talked about it, we discussed it, and sometimes I'll even contact some of my friends, let's say UCSF, Diane Sandman and I have a little hotline to each other to talk about these. And in fact, she's the first person who told me, hey, have you seen these COVID lesions? I'm like, no, what are they? And that day we started to see them. So again, we make sure that we're talking to each other and that we all agree that this is what it is. And so, and we do have a plastic surgeon on our team as well. But we did have to educate our physicians because they would see a wound, and again, what they know is a pressure ulcer. And the National Pressure Injury Advisory Panel put out a white paper about COVID lesions, and that will give you guidance on what to put down, like identifying COVID lesions and how to document on it. So again, we'll write that as a COVID lesion and we start to treat it, and we're just watching for other things that are going on. And remember, these people are on a lot of medications. They're on pressors, they're on steroids, and yeah, and you know, all kinds of medications that are going to impact their skin anyway.
Right. I'd be super curious from some of our hospitals that aren't as big as UC Davis, you know, some of the smaller community hospitals that are CHI insured, what resources they have, and if they have the same kind of, you know, wound naming approach that you guys do. That would be interesting to hear from anybody.
And I find that the more people you have weighing in, the harder it is for anyone to, let's say, take you to court and say, wow, you know, this is what she said. No, we're all saying the same thing. There were 10 of us who said this. There were 10 of us in the room, and we do have what we call wound grand rounds every Tuesday. So we bring all the cases to, you know, a team of people. So on our team is OT-PT, myself, I'm a nurse practitioner, a team of nurses, wound and ostomy nurses, and the plastic surgeon and the dietitian. So we all like, hey, how about this guy? When do you think we can start getting him up? What's the plan for going home? What, you know, what should we call this? How are we going to document this? How often should we follow it? So again, and then we document in the chart, discussed at, you know, multidisciplinary team, wound team rounds. So people know. And then what we do is our plastic surgeon will go to the family and say, look, he's developed this wound, whether it's a pressure ulcer or COVID lesion. We're doing everything we can to make sure that it gets better. And, you know, we're going to follow you until this closes. So even if someone develops a hospital-acquired pressure ulcer, we say, we're going to keep seeing you until this closes.
All right. So I see a chat came in that says, yes, we've seen COVID lesions and also named them that. Excellent wound care nursing team was on the literature. So yeah, you know, another question that that kind of just came up with me when you said that you like to send the waffle cushions home. So if they're going to rehab or long-term care or something like that after they get discharged, do you try to send it with them too, or do you assume that they have those supplies?
No, we try and send them with them. Sometimes some of the nursing homes will throw them out. I'm like, wait a minute, this is going to help, to make sure, because we know this person's at risk. They may not even have a wound yet, because, when you're in a home, from my understanding, you don't order a specialty surface until the patient has a stage 3. We don't want it to get there. We want to make sure we prevent it. And so again, I send it home with people, but also if people are going to nursing homes, I say, make sure you send everything home with them. We pressure mapped the seat cushions, and we compared the Roho cushion, which is $700 for your wheelchair, and it's specific only for your wheelchair. And then we give them the little $16 seat cushion to take home with them. So in case they're sitting in their car, they're sitting, on their couch at home, they're sitting in their easy chair, that they have another cushion that works as well, and it works actually better. But when you ask people, do you want the $16 one? And they'll say, no, I want the $700 one. So we give them both, just to make sure that they have options and they're not left, because oftentimes, again, people are taking long car rides, and it can just start problems there as well.
Right off the bat. Okay, well, I'm not seeing any other questions come in. I'm sure there's lots out there. If anybody thinks of anything afterwards, please, just contact me and I will try to find out the answer for you. I would like to highlight one of the questions on the program evaluation that will hopefully open for you when we end the program. But we're always looking for planning future webinars, and I would appreciate any input you want to give for risk management education topics. So fill that in if you have subject matter that you'd like to hear about, or a speaker you know about, and anything like that. Holly and Emma, this was fantastic information. We really appreciate all of this information. So do you have any closing comments that you'd like to share with us?
I think I just want to say that, a lot of the people in the nursing homes are, most of them are doing a great job. I see people in fact, a few years ago, I did a study. I looked at all the patients who came into the hospital with pressure ulcers. And in fact, they had developed them in the community. And in my evil mind, I thought they were all coming from nursing homes. I'm like, those people are sending them to us on the weekend because it's heavy work and yada, yada. No, they were all coming from home. 75% of the patients who had pressure ulcers that they developed in the community had developed them at home. So they had no care, or family care is all. People who loved them were looking after them, and they couldn't prevent it. So again, I want to apologize for my previous evil thoughts, but I want to say thank you for everything that you do, and you're doing a great job.
Okay. All right, and I will thank everybody for joining us today out in the webinar right now, and have a great day. Bye.
Thank you.
Thank you, Millie.
Bye.